Good morning, everyone. I want to thank Taylor for inviting me to give this presentation. I am Dr. Aisha Nnoli, and I'm a full scope faculty OBGYN physician with Multicare OBGYN Associates. In addition to my private practice, I have the privilege of teaching Tacoma Family Medicine residents and rural family medicine with OB fellows. I also have the pleasure of serving as the medical director for Family Connects Pierce County. Today, we will be discussing preeclampsia. The objectives I have are to provide an overview of preeclampsia within the spectrum of hypertension in pregnancy, define the conditions that comprise hypertension in pregnancy, and review risk factors, treatment, prevention, and resources for preeclampsia. Before I start any presentation, I'd like to begin with the land acknowledgement. I acknowledge the land I sit and occupy today as the traditional home of the Puyallup Tribal Nation. Without them, I would not have access to this working, teaching, and learning environment. I take the opportunity to thank the original caretakers of this land who are still here. We want to respect the gender individuals identify as. Individuals who can become pregnant include cisgender women, transgender males, and non-binary individuals. During this presentation, I'll be using the term birthing individual, unless a gender is specified within a reference study. We will primarily be discussing preeclampsia. Preeclampsia exists within the spectrum of hypertension in pregnancy. Certain hypertensive disorders in pregnancy can increase the risk for developing preeclampsia. For example, pregnant individuals who have chronic hypertension or gestational hypertension are at a greater risk for developing preeclampsia. Hypertensive disorders of pregnancy is a very important topic as it constitutes one of the leading causes of maternal and perinatal mortality worldwide, and it complicates 2 to 8% of pregnancies globally. In the US, hypertensive disorders affect approximately 1 in 23 pregnancies, and the rate is steadily increasing. It also has an economic impact. A 2012 study reported the estimated cost of preeclampsia in the US within the first year of delivery was $2.18 billion. I am using the ACOG practice bulletin titled Gestational Hypertension and Preeclampsia as the main reference for this presentation. Let's review preeclampsia in more detail. Preeclampsia is defined as new onset hypertension and proteinuria after 20 weeks. Hypertension is diagnosed by having systolic blood pressure greater than or equal to 140 or a diastolic blood pressure greater than or equal to 90 on 2 occasions at least 4 hours apart. Proteinuria is increased levels of protein in the urine. It is diagnosed by either having 300 milligrams or more protein in a 24-hour urine collection, a protein creatinine ratio of 0.3 or greater, or a urine dipstick reading of +2 if other methods for testing are unavailable. The term toxemia and mild preeclampsia have fallen out of favor and should no longer be used. Preeclampsia can develop in birthing individuals who have chronic hypertension, and this condition is called preeclampsia superimposed upon chronic hypertension. It is diagnosed by worsening or resistant hypertension, meaning blood pressure is no longer controlled with medications, new onset or worsening proteinuria, and or signs of end organ dysfunction. 25% of patients with preeclampsia will develop severe features. This is called preeclampsia with severe features. Severe features include one or more of the following: severe blood pressure defined as systolic blood pressure of 160 or more, or diastolic blood pressure of 110 or more. Severe hypertension can be confirmed within a short interval to facilitate timely antihypertensive therapy. Also, thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, new onset headache, or visual disturbances, such as blurred vision or spotted vision. When hemolysis, elevated liver enzymes, and thrombocytopenia are the predominant features, it is called HELLP syndrome. Eclampsia is the convulsive manifestation of hypertensive disorders of pregnancy. It is diagnosed by new onset tonic-clonic, focal, or multifocal seizures in the absence of other causes, such as epilepsy, trauma, drug use, etc. Eclampsia is a significant cause of maternal death, especially in low-resource settings. Eclamptic seizures can lead to severe maternal hypoxia, trauma, and aspiration pneumonia. Around 80% of the time, eclampsia is preceded by symptoms of cerebral irritation, such as severe and persistent occipital or frontal headaches, blurred vision, photophobia, and a change in mental status. Postpartum preeclampsia occurs in 5% of preeclampsia cases and is when signs and symptoms are first recognized postpartum. Headache is the most common symptom. It is usually diagnosed within 48 hours of birth, but has been diagnosed up to 6 weeks postpartum. Gestational hypertension is defined as hypertension without proteinuria after 20 weeks. 10 to 25% of these patients may ultimately develop preeclampsia. Now let's review risk factors for preeclampsia. Risk factors for preeclampsia include a past history of preeclampsia. This actually increases the risk 8-fold compared with patients without this history. Extremes of age, so those who are younger and older patients, multifetal gestation, such as twins or triplets, assisted reproductive technology, such as IVF, obesity as defined as a BMI greater than 30, pre-existing hypertension and diabetes, as well as other medical conditions such as lupus, thrombophilias, or kidney disease. Not too long ago, being a Black person was considered a risk factor for preeclampsia. However, we now know this to not be the case. The most recent study to review this was a study out of Johns Hopkins that was published in JAMA December of last year. The study specifically examined differences in hypertension, other cardiovascular disease risks, and the prevalence of preeclampsia among Hispanic, Black, and white women. All 3 groups of women who gave birth and were born in the US had a higher cardiovascular disease risk profile than foreign-born counterparts after accounting for differences in weight, smoking, alcohol use, stress, and diabetes. Data involving Black women showed a birth status outside of the US, and those who lived in America for less than 10 years were associated with a 26% lower odds of preeclampsia. While birthplace status and duration of US residence was not significantly associated with the odds of preeclampsia among Hispanic and white mothers who were born outside of the US. Proposed reasons for this difference seen in Black women include unhealthy acculturation and assimilation, so adopting habits of the dominant culture that increase poor health outcomes. Structural racism. Black women who were born outside of the US but immigrated to the country recently may be somewhat protected from the effects of discrimination because they tend to settle in immigrant-concentrated areas with increased social support. US-born Black women deal with many socioeconomic disparities, including living with the stress of systemic racism, living in racially segregated neighborhoods, lack of access to healthcare services, poor quality of care, and experiences of discrimination. I think it is very important for physicians, healthcare providers, and staff members to be culturally competent and inclusive providers in order to best meet their patients' needs. And it starts by understanding this type of history, as well as the history of medicine in the US, including history of institutionalized discrimination. Institutionalized discrimination and racism in the US medicine has been evident through various unethical studies, forced procedures, and differential treatment administered by healthcare providers and research involving BIPOC individuals. Theories creating and perpetuating racial inferiority, mythology, and stereotypes were taught in US medical schools in the 18th, 19th, and 20th centuries. In addition, there were many 20th century medical experiments in which BIPOC individuals were used without their knowledge and consent. I would like to briefly touch on a few of the many medical experiments performed without consent, as it helps shapes the understanding of why there may be a lack of trust of the healthcare system by some of the patients we serve. Does anyone know where this photo is from? This photo is from the CDC and is of a study originally titled Tuskegee Study of Untreated Syphilis in the Negro Male. In 1932, the US Public Health Services recruited 600 Black men from a low-income area in Macon, Alabama. The recruitment newspaper advertisement for this study was titled, "Free Blood Test, Free Treatment." 399 of the 600 men recruited in the study were diagnosed with syphilis, but never treated. These men were told they were being treated for bad blood, which at the time was a local term used to describe several conditions, including syphilis, anemia, and fatigue. Even though penicillin eventually would become the treatment of choice for syphilis in the mid-1940s, these men were not offered treatment and were observed until they died. Those recruited and their families were never informed. It wasn't until a 1972 Associated Press article brought this to light that an advisory panel deemed the study unethical and instructed the US Public Health Service to provide all necessary medical care to the survivors of the study. A similar study was conducted in 1946 by the US Health Services in Guatemala, which was brought to light in 2010, in which the US formally apologized to Guatemala for the ethical violations that took place. In this study, approximately 5,500 Guatemalan prisoners, sex workers, soldiers, children, and psychiatric patients were enrolled without consent in a study to test the value of different medications in the treatment of certain STIs. About a fourth of those enrolled were deliberately infected with syphilis, gonorrhea, and chancroid. Another historical event that has led to mistrust of the healthcare system is forced sterilization. In the 1970s, 4 of the 12 Indian Health Services regions sterilized 3,406 Native American women. Some of these procedures were performed under pressure or duress, or without the woman's knowledge or understanding. This equated to 25% of Native American women of childbearing age being sterilized. Coercive sterilization also occurred among Black and Latinx individuals during this time. In the 1960s, data from North Carolina showed that Black women made up 65% of all sterilizations in the state, even though they were only 25% of the population. Non-consensual sterilizations of working-class Black women in the South were so common they were colloquially known as Mississippi appendectomies. Similar sterilization happened in Puerto Rico when nearly 1/3 of women were coerced into sterilization under the US government official claim that the Puerto Rican economy would benefit from a reduced population. Most recently, September of 2020, a nurse working at an Immigration and Customs Enforcement or ICE detention center in Georgia came forward with allegations that numerous hysterectomies were performed on detained immigrants without consent. The legacy of medical racism persists today and has contributed to the racial disparities seen. We know that BIPOC individuals are at an increased risk for poor maternal and infant health outcomes. Black birthing individuals are 3 to 4 times more likely to die from pregnancy-related causes compared to white birthing individuals. Identified examples of racism in medicine include BIPOC patient symptoms not being believed, stereotypes such as that Black patients do not need pain medication, are overdependent on government assistance, and the belief that any negative medical outcome is the result of substance abuse or sexual irresponsibility. It is important for us as healthcare providers to acknowledge our own personal biases so we are less likely to act on them. The preeclampsia rate is 60% higher in Black women than in white women, and Black women are more likely to develop preeclampsia with severe features. As mentioned in the Johns Hopkins study, it is not race alone that can explain this statistic. The photo in this slide is a monument in Montgomery, Alabama, called the Mothers of Gynecology, honoring Anarcha, Lucy, and Betsy, who were enslaved women used in fistula experiments by J. Marion Sims without their consent or without pain medication. This monument was created by Michelle Broder. I will now briefly discuss maternal and fetal placental factors that contribute to preeclampsia. I really like this pathophysiology cartoon for preeclampsia as it brings a bit of humor to an otherwise very complex topic. Defective spiral artery remodeling during pregnancy. Normal pregnancy, the vessels at the placental implantation site remodel such that the terminal portions are wide. This allows for a high capacity, low resistance system to provide optimal maternal fetal nutrients and oxygen exchange. In preeclampsia, there is shallow placentation and a failure of the spiral arteries to remodel, leading to suboptimal blood flow between the uterus and placenta. This decrease in oxygen leads to oxidative stress in the placenta and a release of pro-inflammatory proteins, which leads to maternal vascular inflammation, injury, and endothelial dysfunction. The diseased placenta releases pro-inflammatory proteins that cause hypertension, vasoconstriction, endothelial cell dysfunction, and end organ damage. Research has been shown that there are multiple factors contributing to preeclampsia beyond the role of uteroplacental ischemia. Periodontal disease and maternal gut dysbiosis have been linked to atherosclerosis, and this may also contribute to preeclampsia in a subset of patients, as well as the role of autoimmunity, fetal disease, and endocrine disorders. Developing a greater understanding of the various causes for preeclampsia is needed to help improve treatment and prevention. In this section, we will discuss recommended treatment based on the diagnosis and the gestational age at the time of the diagnosis. For preeclampsia and gestational hypertension, delivery is recommended after 37 weeks. Before 37 weeks, it is important to monitor for progression to preeclampsia with severe features. This is done with serial ultrasounds to determine fetal growth, antepartum testing, close monitoring of blood pressures, and weekly lab testing for preeclampsia. Preeclampsia with severe features poses a greater risk to the birthing parents and can lead to many complications, including pulmonary edema, myocardial infarction, stroke, acute respiratory distress syndrome, coagulopathy, renal failure, and retinal injury. Delivery is recommended at or beyond 34 weeks after maternal stabilization. Antenatal corticosteroids, such as betamethasone, are typically given to reduce neonatal respiratory morbidity and mortality from preterm deliveries. Delivery should not be delayed for steroids. When less than 34 weeks, patients are admitted to the hospital for expectant management. Monitoring is done via growth ultrasounds, labs, and antenatal testing. Persistent severe symptoms and worsening fetal status are indications for early delivery, and a multidisciplinary team approach is best for care. This would include your OBGYN staff, neonatal specialists, maternal fetal medicine, anesthesiologists, and any other consultants that are deemed indicated. Here is an expanded list of conditions in which immediate delivery under 34 weeks is warranted. The two main goals during delivery is prevention of seizures and controlling hypertension. Magnesium sulfate is the first-line treatment for seizure prevention. The rate of seizures in birthing individuals who have preeclampsia with severe features is 4 times higher than in those without severe features when they are not treated with magnesium sulfate. The recommendation is to use magnesium sulfate to prevent and treat seizures in those with gestational hypertension with severe features, preeclampsia with severe features, or eclampsia. Magnesium is more effective than anti-epileptic treatments, such as phenytoin, and is started at the onset of severe symptoms or at onset of labor induction. Treatment of severe hypertension is very important. If left untreated, it can lead to congestive heart failure, myocardial ischemia, renal injury, and ischemic or hemorrhagic stroke. Treatment should be given as soon as reasonably possible, ideally by 30 to 60 minutes of persistent severe blood pressure. What can we do to help prevent preeclampsia? Given the complexities of the pathogenesis of preeclampsia, simple approaches for preventing preeclampsia have been unsuccessful. We will discuss interventions that have been evaluated for the prevention of preeclampsia. Low-dose aspirin therapy during pregnancy has been shown to reduce the risk of preeclampsia in patients at high risk for developing the disease by approximately 10 to 20%, and has an excellent maternal fetal safety profile in the second and third trimester. High-risk factors include a history of preeclampsia, multifetal gestation, chronic hypertension, diabetes, renal disease, and autoimmune disease. Low-dose aspirin is recommended if a patient has one or more of these risk factors, or two or more moderate risk factors. It may also be considered with one moderate risk factor after shared decision-making between the patient and their provider. Evidence shows that low-dose aspirin is more beneficial when started between 12 and 16 weeks. There is some evidence supporting the following. Calcium supplementation. Low dietary calcium intake has been associated with hypertension in the general population. It is important for pregnant individuals to receive the recommended daily allowance for elemental calcium through diet and/or supplements. In the US, the recommended amount of elemental calcium is 1,000 milligrams a day in those between the ages of 19 and 50, and 1,300 milligrams in those between the ages of 14 and 18. Pre-pregnancy weight loss in those who are overweight and obese. One study found a reduced risk of recurrent preeclampsia in obese individuals who had weight loss in between pregnancy. Exercise. Studies have shown a reduced odds of developing preeclampsia in pregnant individuals who exercise at least 3 days a week. What are the long-term risks in those diagnosed with preeclampsia, and how can we provide support? Birthing persons with pregnancy-related hypertensive disorders are at an increased risk for hypertension, cardiovascular disease, kidney disease, and overall all-cause mortality. It is important to establish a transition to a primary care provider after pregnancy for monitoring and prevention strategies. Hypertensive disorders of pregnancy caused 6.8% of pregnancy-related deaths in the US between 2016 and 2018. Between 2014 and 2016 in Washington state, hypertensive disorders accounted for 10% of deaths in pregnant individuals. Also important to note regarding Washington state maternal mortality statistics are the race-ethnic disparities. American Indian or Alaska Native birthing individuals have a maternal mortality rate 9 times that of non-Hispanic white individuals, followed by non-Hispanic Blacks who have a rate 1.9 times greater, and those who are multiracial at 1.9 times. The Hear Her campaign is a national initiative sponsored by the CDC to help prevent pregnancy-related deaths by sharing potentially life-saving messages about urgent maternal warning signs. I encourage everyone to visit the CDC Hear Her website to learn more about individual birthing experiences and resources available. This is a photo of Allison Felix, a track and field athlete and Olympian who shares her story of her preeclampsia with severe features which was diagnosed at 32 weeks. Many are also aware of Serena Williams, the 23-time Grand Slam tennis champion who had pulmonary embolism after giving birth. When interviewed, Serena Williams recounted that when she had asked a nurse for help, the nurse responded by saying, "I think all this medication is making you talk crazy." In the article, Williams said the problem related to high mortality of Black women in the US could be medical professionals failing to listen to Black patients. The Hear Her campaign encourages partners, friends, family, coworkers, providers, and anyone who supports pregnant and postpartum individuals to really listen when being told something doesn't feel right. The CDC Hear Her website has many available posters to download, such as the one shown here. We are fortunate to have community resources here in Pierce County, such as the AHA Check Change Control Hypertension Management Program that Johanna and Sharon will be discussing. We also have the Family Connects program. Family Connects Pierce County is currently serving those living in 98444, 98408, and 98499 zip codes, regardless of socioeconomic status. Family Connects links experienced nurses to families and provides a bridge to resources within the community. I strongly encourage everyone to visit the Family Connects Pierce County website to learn more about this amazing program. Family Connects also hosts free weekly gatherings for Pierce County families called Baby Lounge. It is a safe space for all families with babies to connect and learn together with other parents. Please visit the Family Connects website to learn more. Thank you for your time, and I welcome any questions you may have.